Morning. Where's John Horrigan? Hey, John. Never seen John face to face, so that's a pleasure to do that. I definitely would like to thank the organizers for asking me to come today. And there are lots of good old friends in the room, so it really feels it's a pleasure to be here. How do I advance? Okay. So let me back up. So I'm Chris Daugherty from the University of Chicago. I'm an IRB chair and cancer researcher. And I'm going to play my role here as a stakeholder. I'm an IRB chair. I'm a local IRB chair. And so I've renamed at least my portion of the talk, Challenging the Successes of Review and Oversight of Multi-Center Cancer Studies. So these are assorted thoughts, somewhat visceral, I suppose, what I call caveats and potshots from the front line. And I'm going to figure out how to do this sooner or later. So I'm going to play the role here as a devil's advocate, basically a grumpy old man where the grass is never greener. And I'm going to provide my added personal perspective as a cancer clinician, researcher, and local IRB, again, participant stakeholder. And I want to spend some time discussing an issue because I think it needs to be parsed out, this issue about local IRB performance, and specifically as it relates to time that it takes to do a review, and what have been called, in quotation marks, IRB review times. And I want to examine the published data, and I actually want to look at, if you're willing, to look at some of the concepts that are involved here. These are logistical and practical concepts, and they're philosophical as well. And then briefly, I'll try to touch on other assorted issues, and I simply want to add to the conversations that have already been had. It's clear that not all IRBs are created equal. The ability to do what the Harvard system has done with the CTSA is probably unparalleled and a model, but not one that 90% of institutions are going to be able to do. And so the distinctions between community-based IRBs that will participate in multi-center studies and not have the resources to do things well or do them perhaps at all, compared to more traditional academic institutions that may at least have confidence that the things that they're doing they can do and do well. The issue about loss of a local valuable resource, which may or may not be the case, but it certainly is a perception, and I think one that David alluded to. And the shift, not to the central IRB, the shift within the institution with regard to administrative burdens. And we'll touch on that briefly. And then I think it deserves mention. I mean, it is called the NCI's central IRB, but of course it is outsourced to a CRO. And the members of that IRB are, whether it's an honorarium or not, they're paid to do so. So, gee whiz, I apologize. So I'm a product of my institution. I'm 20 years now, I think, nearly 20 years as a practicing medical oncologist, equal amount of time as a cancer researcher, and I suppose with a relatively unique perspective in that my research has focused on issues related to ethics in clinical trials, specifically in cancer care, issues about informed consent, and issues about cancer care communication and decision making. And I have been the beneficiary of peer-reviewed funds. I put this up here not to blow my horn, but to thank Mary McCabe one more time, because she was vitally responsible for some of my peer-reviewed funds, and perhaps to thank Rich Shilsky, too, as a mentor to me. I have, for 17 years, I've been a member of our local IRB, initially as a member, then as a vice chair, and then as the chair for the last 7 years. And I'm actually a current member of the NCI's central IRB. It is possible by the end of this talk I'll be neither of those things. And then I'm a product of my institution. I'm a product of the University of Chicago, and I'm a product of our IRB. And what I would tell you is that I think our IRB is unsurpassed. I'm not saying that we're not passing anybody, but I'm saying that we're unsurpassed with regard to experience. We currently average nearly 2,000. We are overburdened and under-administrated. We average 2,000 new protocols per year, tens of thousands of continuing reviews that we do. We've, of course, been formally in operation since HHS issued their regulations in the 1960s, 66, whatever the. But we grew out of some of the, but we also grew out of some of the earliest federal regulatory processes governing clinical research. Is Ruth Faden still here? So the Radioisotope Review Committee that was established in the 1940s at the University of Chicago was the predecessor to IRB. We are the birthplace of informed consent. If you want to read Professor Faden's Advisory Committee on Human Radiation Experiments, published by Oxford Unity Press in 1995, you'll see that history. We are the birthplace of informed consent. So we have the highest level of cancer clinical research expertise. It's embodied in Rich, who's here today. We were, if the term can be used, the host of the CLGB for more than 10 years, still are the host to faculty members who play a vital role in the administration of the CLGB. We're one of those comprehensive cancer centers. And we have an extraordinary level. We are recognized as having an extraordinary level of expertise in cancer clinical trial design and conduct, particularly early phase. We're one of how many institutions? 5, 6, that carry both the NCI's phase 1 grant to conduct phase 1 trials and the contract to conduct phase 2 trials. Again, I don't say this to blow a horn. I say this to say that I'm a product of my environment, and so whatever it is that I'm saying presumably comes from this environment. All right. So this is going to sound like I'm in a fight with Dr. Shilsky, but I'm not. So the studies that were presented, that I'm going to summarize them. I'm going to paraphrase them, perhaps editorialize them a bit. But local IRB review of multi-center studies results in rare protocol changes and changes to informed consent that are rarely meaningful with much time consumed. So response 1, let's get rid of it. Let's get rid of the local IRB review process. Response 2, sometimes I feel like saying, well, you're welcome. I guess nearly half a century of training cooperative groups and their investigators on how to write protocols, relative human subject protections, and how to create consent forms that appropriately document, I'm not talking about documenting understanding, but document the federally required elements of informed consent has paid off. They've become so good that they don't need us anymore. So my point here is there are questions to consider. Of course, the absence of evidence is not evidence of absence of meaningful review, as Dave said. This issue about time, what amount of time should it take to ensure that the protocol, consent, et cetera, do in fact effectively address human subjects' concerns? Are no meaningful changes evidence of nothing meaningful being done with regard to the review process? My analogy here, you can take issue with it, is that we ought to get rid of the local cops because 99% of the drivers obey traffic laws and we have the county sheriff anyway. My dean at my medical school pays a portion of my salary to be the IRB chair. I think it's about 45%. So this is the way I feel 45% of the time. Okay, further, published data presented. Conclusion from these studies, the local IRB results in much time consumed. And in the general scheme of a clinical research timeline, how much time does IRB really take up? Consider the time from the cooperative group protocol concept to enrollment of the first subject. This is what this is about. This is about getting to the point where we can get the trial to the subject, getting that first subject enrolled. Depending on how you look at the data, I can tell you that less than 2 to 3% of that time is taken up by IRB review, and that time is rarely in isolation. There are other things going on while that IRB process is taking place. There's no doubt that that study is eventually going to be reviewed. There's no doubt that nurses have to be assigned to understand the eligibility requirements, because many of the investigators never will. And so there's lots of things still going on. As well, consider, and is it really about the enrollment of the first trial, well, the first subject? Of course it's not. It's about completion of enrollment, right? It's about completion of the enrollment of the 1100th patient on the trial. And so if we consider and there are trials that of course never finish accrual, but consider the time from the cooperative group protocol concept, just from that point, there are pieces even before that, to the enrollment of the last subject. IRB review probably takes up less than 1%, and again, rarely in isolation. Now, what I would also say is that as we presented the data and discussed it, that quote-unquote local IRB review times may or may not be IRB quote-unquote review times. What are these times measuring? Is it measuring the time it takes for an apathetic PI and a gun-shy cancer center administrator to respond to IRB review comments? Oh my God, one more time, wordsmith in the consent. I'll get around to signing off on that sooner or later. Oh my God, I got to go to the investigator and tell him that the IRB's wordsmith in the consent forms again. I think I'll wait till tomorrow to do that. And what about review times? I don't know that for sure, but most of these, certainly the review of the published data is not taking into account review times if these are important in the age of electronic IRB submission and tracking. All right, so local IRB review results in too much. Presumably when it's much time consumed, we're saying it's too much time. However, again, are there equally and more meaningful times to consider? That is, what I never know is the time it takes when the PI, the administrator, the institution receives the cooperative group protocol to the time the protocol is submitted to the IRB. As when it shows up in the mail, when it shows up as the attachment, how long does it take to get it funneled to the local IRB? I have suspicions that at least on some occasions that time is actually longer than the 100 or 200 days, because we see protocols come in and their dates are calendar years that are preceding the submission. So again, in this issue about the time it takes from when IRB approval is granted to the time when that first subject is enrolled. And it must be understood, I think, that in specific regard to time, the only time that a centralized IRB can conceivably save in regard to this time is the time of the initial review, because everything else occurs in real time continuously. So what we're going to say with a centralized IRB, please don't misunderstand my criticisms of the process, but what we're going to save in time is the time of initial review. At minimum, in the overall desire to improve the cancer clinical research regulatory process, right? That's the fundamental principle that we're operating under. We should find, as Rich said, better, more precise, and more meaningful metrics than IRB review times. We have to find those metrics to know whether we're doing it right. Because, as Dave said, if we go from 100 days to 14 days, is 14 days too fast? 14 days awful fast. Now, it's just a cooperative group study that's been highly vetted 100 times over, but it is awfully fast. Maybe it's the right time. I don't know. All right, too much time consumed. Well, how much time should the IRB review process take? And I apologize, John, but we've talked about some anecdotal experiences. We've discussed local IRB anecdotal experiences. I'm going to discuss anecdotal experience from the centralized IRB. I think John knows from one or two emails that came shortly after a recent meeting that I had some questions about this. Here's an anecdotal experience. Central IRB committee, the committee members, spent less than 5 minutes discussing annual review of 2 large cooperative group trials, encompassing more than, I think, 2,000 subjects, thousands of summarized reported toxicity reports and adverse events, and that came from dozens of local cooperative institutions. Now, in the absence of local IRB review, and the use of an independent model of a centralized IRB, there will be no other review of such ongoing research from a human subject safety protection standpoint. At best, the centralized IRB continuing review process is a view from 30,000 feet. I'm speaking in IRB language, but right, IRBs are required on at least an annual basis to re-review any research that's been proposed involving human subjects. So IRBs do an annual review. Tell us what you have done in the last 10, 11, 12 calendar months. Now, in the end, this 30,000 feet viewpoint may be adequate, but this relative, and I recognize that its relative lack of more granular review needs to at least be acknowledged. There is no intuitive reason to believe that human subjects risk would lessen or protections increase in this context of continual review, not intuitively. There may be arguments to say that because it will prevent misinformation and a bunch of IRBs doing contradictory things. But that just means the IRBs, the local IRBs, are doing it wrong. It doesn't necessarily mean that they can't do it right. So if you'll allow me to get somewhat philosophical here. Again, this issue, how much time should an IRB review take? Quoting from Hans Jonas, this is probably either all of it or some of it is the most quoted statement about human experimentation, and it's right at the time of the late 1960s. So let us not forget that progress is an optional goal, said Hans Jonas, not an unconditional commitment, and that its tempo in particular, compulsive as it may become, has nothing sacred about it. Let us also remember that a slower progress and the conquest of disease would not threaten society. These are Jonas's words, not mine. Grievous as it is to those who have yet to deplore that their particular disease be not yet conquered. But that society would indeed be threatened by the erosion of those moral values whose loss, possibly caused by too ruthless a pursuit of scientific progress, would make its most dazzling triumphs not worth having. Time alone cannot be used as a measure of quality of IRB review. Okay, so that's the issue about time. And then just in a few remaining minutes, I would then point out some other issues, which I think have been covered a little bit by others this morning. But again, not all local IRBs are equal. There is a varying degree of interest, expertise, commitment, and resources available to them to do their job. I do think, and I realize that this may be somewhat self-serving, that loss of local IRB attention is loss of a local valuable resource. Now you would say, well, it's all relative. It's a multi-institutional cooperative group study. You really don't need local resources to do this. But I think most IRBs do see themselves as service organization providing valuable guidance and advice to clinical researchers. In the CIRB, in an independent, not a facilitated review, because that's no longer what we have, it's an independent model of a centralized IRB system, this resource will be lost, at least relative to the specific PIs and the involved trials. There will be no in-house support for your unanticipated problems. You will have to contact John, Central IRB, and figure out whether that death on study needs to be reported. And I suppose to some extent this is the liability issue, and I understand that there are ways to deal with this, but institutions will have to get used to how to carry the water, and cancer centers and investigators have to carry the water without the IRB involved. And I think the issue about, is it an unanticipated problem? It's never a no-brainer often that it is. And the issue about whether or not it qualifies as noncompliance needs some interpretation, and sometimes people like to have somebody local to talk to. There is a shift, potentially even an increase, I think, depending on the institution and how they do this, of the local administrative burdens. So while the IRB won't be involved and there is a reduction in IRB burden, there still are going to be shifts. IRB currently tracks, monitors conflict of interest. The cancer centers are going to have to somehow do this themselves or find the resources in the institution to do this. That $107,544 spent on IRB review with an independent model, that number will go down, but it isn't going to go down to zero because there's still, within that $107,000 is a significant amount of administrative burden that will still have to be pursued by the local institution. So some additional institutional resources will have to be created. And I think that at least at our own institution, I'm not speaking for the IRB, we in fact probably welcome the centralized IRB and the independent model. But there's a modest level of administrative panic within our own, what I see as highly experienced and professional cancer center with regard to protocol and consent tracking, COI, lack of in-house support and advice. If an investigational drug is involved, the IRBs have become relied upon to provide all these resources. We are the only resource notifying the investigational drug services that there's a new trial with an investigational drug coming. And in the absence of the IRB, cancer center administrators are having a hard time figuring out how to get that done. It'll happen. Lastly, I think it's a relatively minor issue, but I think it deserves some discussion. No offense, in quotation marks, the NCI Central IRB, we are paying for IRB review, and we are paying the IRB members. I'm one of those members. The NCI, CIRB, is outsourced to MS Corporation, the CRO. Also, albeit small, but I would even say that relative to how we track these things now, where every disclosure has to be tracked, and a determination of whether it's significant or presents a significant conflict, that the CIRB members, they are paid to be the IRB members. And at least at the local level, this has been contrary to long-standing local IRB models. It may be okay, but I believe that it comes with its own relative risks, expectations, and challenges that have to get acknowledged and discussed. Thanks for listening.